My greetings to everyone. I am Dr. Yashdeep Gupta, and I have with me Professor Nikhil Tandon, who is head Department of Endocrinology at All India Institute of Medical Sciences, New Delhi. Welcome, sir. Sir, this year we are
Thank you,
celebrating.
Yashdeep.
This year we are celebrating 100 years of insulin discovery, and it is important to reflect at this point at what we have achieved in the last 100 years and what we need to do so in the future. So in this regard, my first question to you is like, what was a life for a patient with diabetes before the discovery of insulin, and how the discovery of insulin has changed that scenario for a person with diabetes?
It's a very pertinent question, Yashdeep. The one-line answer before I expand on it is before the discovery of insulin, diabetes, as we know, type 1 diabetes was mostly a fatal disease. And that is a reality of life in those days. In 1921, effectively, when somebody was given the diagnosis of diabetes, it was like being given a death sentence, with children or young adults destined to die within a few months. And by and large, what was being done was they were kept alive by a starvation regimen, which reduced them to become things like walking skeletons. There were very, very strict diets with minimal carbohydrate intake, so much so that patients would, if they didn't die of diabetes, they died of starvation itself. If you look at historical material from the early part of the 20th century, you'll find, and I'll share a diet prescription with you, 7 grams of proteins, 6 grams of fat, 15 grams of carbohydrate. That's a total of 150 calories. As you know, even the very low calorie diet, which we use today, is about 800 calories. So that is the extent to which people were being treated regard caloric restriction. But before I go to the impact of insulin, I think it's important for a lot of our younger viewers to be acquainted with the narrative about how the key milestones were for insulin discovery. In a year like COVID, in a year when, because of COVID, we've all marveled at a disease which was not known till last year. We've gone ahead and made a vaccine, which is now developed and introduced for human use. But look at what the journey of insulin was like. So Banting opened his medical practice in London, Ontario in July of 1920, right? That's about 101 years ago. October 1920, he came up with the general idea of trying to extract insulin from the animal pancreas. He met Professor MacLeod in November 1920. So, from the starting of a practice in July to meeting somebody in November, by May 1921, the lab was established and Banting and Best began their experiments. In July 1921, 2 months after the experiments began, they had tested activity of the crude extract in pancreatectomized dogs. By January 1922, that's 6 months later, they had tested activity of crude extract in human beings. The paper was published in 1922. March, the patent was filed in June of 1922. And by August of 1922, Eli Lilly had started shipping commercial grade insulin. So July 1920 to August 1922, in a time when technology moved slowly, there was no emails, there was no internet, there was no automation. Within 2 years, this had happened. In October 1923, Banting and MacLeod got a Nobel Prize. That is an amazing story. What this story did was it produced insulin which transformed those affected into apparently healthy individuals over a very few short weeks. Many of them went on to live full and productive lives. But the question is, what did it do to the lifespan of a person with type 1 diabetes? By 1945, a child diagnosed with type 1 diabetes at the age of 10 years could expect to live more than 30 years longer than a 10-year-old child diagnosed with type 1 diabetes before the discovery of insulin. So assuming this age of diagnosis at 10 years, before insulin, lifespan after diagnosis was 1.3 years. In 1945, it became 35 years. Today, the lifespan after diagnosis is about 60 years. But that is a story of high-income countries. In low and middle income countries and low income countries, the average lifespan are still nowhere near what I mentioned above. And even more importantly, the duration of existence is plagued by multiple significant health issues and extremely poor quality of life. And those are issues related to access to insulin and monitoring of glucose. So clearly, there was a significant impact on survival. But as you know, there is a quantity to life, but there's a quality of life. And that is another story. And let me just sort of wind up this part of the conversation by saying that there was a lot of optimism that ready availability of insulin would result in a cure for a previously fatal disease. The word I emphasize is cure. But this was gradually replaced by realization that insulin was not a panacea. Over the years that followed, many of those in treatment began to develop severe microvascular complications resulting in blindness, kidney failure, amputations. Embarking on a pregnancy with diabetes was perilous for the mother, but even more so for the unborn child. 25 years after insulin was introduced, perinatal mortality in a person with type 1 diabetes was 50%. So it became very clear over a period of time that it was not merely insulin, but keeping glucose levels close to normal that was going to be the key for survival and quality of life in people with type 1 diabetes.
Thanks, sir, for bringing some useful tips, especially for the younger viewers. So, as you said, that discovery of insulin had brought a lot of optimism, but has also you mentioned that there is still a lot of gap between the anticipated outcomes after introduction of insulin and the reality at the ground level, especially for the developing nations. So, why is it so?
So I'll try and answer this in three broad areas. One, I think an important topic. We live in India, a low middle income country with a fair number of people who have very limited incomes, and also a country where a large majority of people, 80% or even more, have to pay for their treatments out of pocket. There are no support systems. So I shall talk first about affordability. I will then talk about the implications of a relative monopoly of production, which is limited to a handful of manufacturers. And then I will talk about issues related to access, exclusive of cost. So let's talk about cost first. Let's not even talk about India. Even in a high-income country like the USA, the average price of insulin has nearly tripled over the last decade. And this high cost of insulin has become a barrier to diabetes treatment. On this 100th anniversary of insulin's discovery, the life-saving treatment of insulin, especially for type 1 diabetes, is financially out of reach for as many as 1/3 of people with diabetes across the world. Let me remind you of what Banting had said. Banting said, insulin does not belong to me. It belongs to the world. In January 1923, Banting, Best and Collip were awarded an American patent for insulin and their method of making it. And you know at what price they sold this patent? They sold their patent to the University of Toronto for $1 each, right? So the discoverers and the inventors did not make money out of this. It's the subsequent development, commercialization, which has really enhanced the cost. Of course, there have been innovations, and they of course will cost money, but I'm not sure if the enhancement of cost is explainable or justifiable to the extent that it happened. The high cost of insulin has been associated with underuse, which can lead to increased risks of short and long-term complications. Again, if you look at global data, about 6.5% of patients in high-income countries, approximately 1/4 to 1/3 of people in a country like the US, and between 1/5 and 2/3 of people in low and middle income countries report skipping insulin because of issues related to access or cost. This issue of affordability is even more important in as I said, in low and middle income countries. The prospective urban-rural epidemiological study, the PURE study, which a lot of us are familiar with, was a prospective cohort study involving 22 countries, and it provided a global perspective on the availability and affordability of essential medicines for diabetes, including insulin. They reported that an estimated just under 40% of households of individuals with diabetes were unable to afford insulin. And that ranged from 3% in high-income countries to just under 50% in upper middle-income countries to 35% in lower middle-income countries and 63% in low-income countries. Fortunately, it was about 50% in India, which is better than other low-income countries. But that's still a lot of people who cannot afford insulin. The increase in expenditure was also, unfortunately, significantly contributed by a change in prescribing practice from the less expensive animal and human insulins to the more expensive insulin analogs, and then by an increase in the price of all available insulins. We will talk a little bit more about this, but I think it's important to point out here itself that conventional human insulins, NPH and regular, may be appropriate alternatives to more expensive analogs. So a lot of people, virtually most people with type 2 diabetes, and even several people with type 1 diabetes, and I don't think we should be fixated on only using more expensive insulins. It's not that the more expensive something is, it becomes ideal. So that's point number one. The second issue was a relative monopoly of manufacture. I'm not going to take names, and that's not the intention, but the global insulin market is dominated by less than 5 multinational insulin manufacturers, right? These companies control about 99% of the market by value and 96% of the market by volume. Now, this has implications to both access and cost. Let me tell you a story about, and again, I won't go into specifics, but about 20 years ago, there was this whole debate because we had reached a cusp of transition from animal to human insulins. Obviously, there are several advantages in purer insulins and monocomponent insulins and human insulins, and I'm not debating on that. And I'm not even saying but that shouldn't be the case. But there was no doubt that at that point in time, human insulins were significantly more expensive than animal insulins, just like today, analog insulins are so much more expensive than human insulins. So several voices in the medical community, several stakeholders, patient groups were keen that animal insulins persist in the market to cater to a clientele which could not afford more expensive insulin. Any insulin is better than no insulin. But the key issue was that if a manufacturer stops supplying a certain type of insulin, the discussion becomes purely academic. So we have to prescribe, or we can prescribe only what is available. We are very fortunate in India to have the entire range of insulins, of conventional, latest generation analogs, everything. But I was recently in a conversation with colleagues in Africa, and that they are for a large part compelled to prescribe analogs because that's what the manufacturers send them. And a larger community of manufacturers, therefore, would be very useful to enable a range of products at a range of price. And that is something which I think we must try and ensure. The third point, as I mentioned, was accessibility issues other than cost. Going back to the Pure study once again, Pure reported that insulin was available in about 50% of pharmacies overall. That means half the pharmacies in the world do not keep insulin. 95% of pharmacies in high-income countries, only 40% in upper middle-income countries, only 30% in lower middle-income countries, and only 10% in low-income countries do not keep insulin. Once again, India is very well placed. 76% of pharmacies in India keep insulin, which is nearly twice as much as in upper middle-income countries, right? But look at the world as a whole. In India also, even where it is accessible or made accessible by a lot of companies, and I must give them credit, the insulin manufacturers have a lot of CSR initiatives, there are NGOs who do it. We end up giving supplies for a very short period of time because we can't keep giving them 3 months of supply. We'll run out of it. Cold chains are often not maintained too well. People end up underdosing because they're not sure if that supply they've been given will run the course of the prescription. We all have experience of advising patients how to keep insulin without refrigeration, without electricity, in pots of water, all sorts of things. How can we forgive ourselves if a child dies because we could not make a life-saving drug available 100 years after it was commercialized. So I pointed out the problems. Let me try and make a couple of small suggestions in terms of as solutions. I think professional organizations like the Endocrine Society of India, like the Research Society for the Study of Diabetes in India, by the physician conglomerates, government agencies, insulin manufacturers, pharmacies must all work together to ensure the accessibility and affordability of insulin for all people with diabetes. Policies can be implemented to improve insulin access and affordability. And these include clinicians should be encouraged to prescribe lower cost insulins where they feel it's not going to impact significantly on care, encouraging generic and biosimilar insulins, enforcing more stringent requirements for patent extensions and market exclusivities, which is a commercial decision, increasing transparency in the drug pricing and distribution system. All of these are important, and I think hopefully they will address some of the issues which I've raised above.
So you brought about three very important points. One is affordability, second, access to insulin, and third, monopoly by certain multinational companies. So first part of my question relevant to these 3 points is that, as you know, that many people in India and in many developing countries, as you said, that pay for insulin from their own pocket, and many are below poverty line, as we know. So affordability is one of the major issue. So my broad question in this regard is that how we can overcome these challenges, and specific question is that are analogs better than conventional insulins given the huge cost difference between the two? Second important point you mentioned regarding the regulatory authority at national level in India, has mentioned that we stand better compared to many developing nations. So, for example, if some pharma company wish to help other developing countries, regulatory approval is in each country is an additional barrier to access. So can we have some process similar to approval of COVID vaccines as we have seen in the last 2 years by global bodies like World Health Organization, which can take care of some of the such sort of barriers? So your viewpoints?
So once again, 3 very important points. Let me start with the whole issue of cost in relation to changes in prescribing practice. The increase in expenditure for insulin, there is a definite and significant contribution of prescribing human insulins less and prescribing analog insulins more. There is a general increase in the price of all available insulins, but this transition of human to analogs is a definite contribution. I think clinicians and patients must carefully weigh the advantages and cost of insulin therapy, and must carefully weigh the advantages of the type of insulin therapy. We all know the scientific benefits of analogs in certain instances, the issue about duration of action, the issue about potentially less hypoglycemia. I'm not putting that into debate. That's been well debated and well understood. But the issue is all sorts of insulins will be required. And if a person, and we both work in a government setting, we know that even using conventional insulins is out of reach of so many people. So one has to be very, very careful about it. And I think that, we shouldn't be obsessed and fixated about shifting everybody to analog insulins. People with type 2 diabetes, including those with a less A1C goal, a lot of people with type 1 diabetes, all of them can still be managed with conventional insulins. And I think we really need not to instinctively prescribe only analog insulins. Of course, we should prescribe them wherever it is feasible and affordable, but it should not become a universal prescription. I think about the regulatory authorities, again, is a very, very important, and I must, again, highlight a lot of positives which India has done. So I think about the drug price control order which the government has. This was initially brought in 1995 for bulk drug purchase. But then there was a Supreme Court order subsequently and a committee called the Pranab Sen Committee, which led to a revised drug price control order. And that has been operational since 2013. This has now extended from bulk drug purchase to formulations. And they have included any drug which is part of the National List of Essential Medicines, the NLEM, which is an initiative made by the WHO, to be included as part of the DPC or the drug price control order. 3 formulations. So these are all conventional insulins. Regular insulin, NPH insulin, and a 30/70 premix are now part of the drug price control order. And that has led to a ceiling price to be fixed by the government. There are domestic manufacturers and international manufacturers. For domestic manufacturers, the ceiling price fixed was about 150 rupees for a 10 ml vial of a 40 unit per ml insulin, right? This can actually be made available even at a further lower cost to the Prime Minister Jan Aushadhi Yojana. So instead of 150 rupees, about 70 rupees. And these domestic manufacturers are allowed an annual increase of just under 2% in the cost. So that's a real rate. So that means 1 unit of insulin is costing about 35 paise. Very few countries in the world will you find this sort of cost. For international manufacturers, they are allowed a profit margin of about 50% above cost of production, right? And so this is fine. This is not for analog insulins at the moment. This is only for conventional insulins, but at least for a country where the poverty line is decided by somebody who earns between 37 and 42 rupees per day, depending whether you're rural or urban, this is a fairly reasonable effort by the government, and I think they should be applauded. So that's the local cost. The other thing which you actually made, and a very important point, the emergency use authorization by the WHO for COVID vaccines, there is an entity called the pre-qualification program. Now, you'd be familiar that in 2013, or around that time, there was a UN high-level meeting on which brought NCDs into focus. But over the last year or two, since especially the last World Health Assembly, there has been a significant focus by the WHO on diabetes as a specific NCD. So the Global Diabetes Compact is a new initiative made by the WHO. And amongst the activities of that compact is an effort to bring a set of targets which are going to be proposed to member countries. And I will not like to go into details because this is still work in progress. I am fortunately somebody who is associated with this effort, but pricing of insulin and more importantly, access to insulin is an important discussion in that program. Now, the pre-qualification program is already available for several medicines, but if as the consideration of insulin being brought into pre-qualification means that small manufacturers, if they get pre-qualified, they may be allowed access to several countries without having to apply for regulatory approval for each country separately. So like one blanket program. Now, we will need to see over a period of time how successful this is, but clearly this is a potentially new avenue for, let's say, a small country manufacturer, not a global giant, to get an approval and then allow their insulin to go in. And they may not even be in competition with large manufacturers. If the large manufacturers are predominantly selling analogs, these smaller companies from smaller countries can actually end up just providing conventional insulins, but the access ensured through that pre-qualification process if individual countries accept that as a regulatory pathway.
So thanks, sir, for your elaborative thoughts into these major issues. But is making insulin available sufficient for achieving the desired outcomes? Like, what are the additional areas we need to focus upon?
So again, and I think we talked about it a little earlier on, that it's not merely providing the insulin, it is to ensure good control. And therefore, monitoring becomes a very, very important part on people who are taking insulin. So let's go back again historically, right? Initially, when insulin was introduced, blood glucose measurements were actually only available in hospital laboratories. Doctors relied on a single glucose measurement at hospital visits and sometimes with associated urinary glucose records in between. The challenges of meeting targets were immense. Episodes of severe hypoglycemia were common, and therefore many people said, it's safer not to have a hypo and we'll let the sugars be high. In the late 1970s, two pioneering workers from Germany, Berger and Mulhauser, realized that they could encourage patients to measure insulin at home and then contribute to their own management of diabetes. They advocated what they call an insulin treatment and training program, but emphasized structured education to teach self-management. Surprisingly, the benefits of these results did not get taken up by most healthcare professionals across the world for many years. In fact, for many decades. It was possibly about 30 years for diabetes establishments across high-income countries, including other European countries and UK, to adopt this standard of care. You'd be surprised to know that even today, for example, I'm just giving you data from the UK, around 40% of adults with type 1 diabetes are offered a structured education program in the UK. Only 10% participate, right? And what has been shown, and this is high income, but what has been recently shown in two very large multinational surveys involving participants with type 1 diabetes from the Middle East and Latin America, that those who received diabetes education were more likely to practice self-management and 1.5 times more likely to attain the target A1C than those who did not. And this clearly demonstrates that we must encourage education, we must encourage management, and we must encourage monitoring, right? And therefore, the whole issue about monitoring, technologies for monitoring, glucose monitoring by capillary blood glucose, and now more advanced technologies for monitoring, coupled with education so that the patients and their healthcare professionals can understand and interpret those monitoring records becomes important. Because the most important thing, as far as I'm concerned today, is a realization, and that realization must be there for all healthcare professionals, that it is not them who are treating the disease. It is the patient who is treating the disease, not month by month, not day by day, but hour by hour, and in terms of newer technology, minute by minute. And therefore, the partnership between the patient and the professional would be the single most important incremental initiative in the management of type 1 diabetes.
So you just brought about the word technology in care of diabetes, especially in type 1 diabetes. So technology obviously has many advantages, but it also comes with its own disadvantages. And one major issue for, especially for developing nations or poor people, is a cost. So what are your views regarding that part?
So I'm a big supporter of technology. I think technology is critical. And you all know, if you look at even the history of insulin, the innovation from, conventional insulins to more pure insulins, to monocomponent insulins, to recombinant human insulins, to analog insulins, to longer duration insulins, to insulins with less variability. It's been phenomenal. Also, as I just mentioned, in terms of monitoring, the ability, instead of having to do urine glucose monitoring, and I belong to a generation which actually has managed patients with urine glucose monitoring, to self-monitoring of blood glucose. As a resident, I still remember we used to have old meters in which, you had to wait a minute after applying the drop, then you had to wash the strip, then blot the strip, then put it into the meter. So imagine, it used to take so much time to do one blood glucose. And as a resident, obviously, you were in a hurry, you wanted to do so many more. From then to meters which give you a result in 5 seconds, to meters which give you ketones, to now sensors. So it clearly has made insulin delivery, the care of patients, easier, convenient, and efficient. So I'm not disputing that. Right? The bringing in the continuous glucose monitoring, hybrid closed loops, times in range, all of that is substantive. But listen, how many people can afford that in a country like India, right? In fact, the global data is that about 40% of those who are prescribed glucose sensors, even in those places where the sensors are available as part of insurance or government subsidies, either do not use them effectively or return them. So the problem is, technology is important. It has added, but there is still a cost gap which we must understand. In many developing countries, including India, we cannot afford these. And I think we need to continue to understand that there are broad principles of technology, of monitoring. There are broad principles of management. There should be a cafeteria choice of tools and technology to achieve these. And there is no point saying that, well, if you can't get a CGMS, I can't treat you. You have to manage people. So in some senses, you're very right, the gap has increased, and therefore the message again for people practicing in India, especially those who look after the less affluent population, is learn about technology, use when feasible, but also remember there has to be other methods of managing patients. Otherwise, we will allow our less advantaged or economically advantaged patients to suffer, which is really not an acceptable thing to do.
So rightly said, sir. Many thanks for your time. I hope we all collectively will be able to achieve our goals for the well-being of people living with diabetes. So thank you so much, sir.
Thank you so much.
Thanks everyone for listening and being part of this conversation. Thank you so much.